Good morning, good afternoon, and good evening from all parts of the continent and the world. Welcome to our special session number 23. It's a series of COVID-19 related sessions that we have dedicated to diagnostics in the COVID-19 pandemic. Today we have an exciting subject that has been spoken over time, even on previous sessions. Today we are going to be focusing on COVID-19 antigen testing. We know very well that the most reliable test so far has been real-time PCR. However, the challenges that we do have and that we have seen throughout the world is these are not always available, and where available sometimes need specialized staff. As we try to make sure that we ramp up testing, we scale up testing, since it is the bedrock of control of the COVID-19 pandemic, we have always been searching and searching for a test that will be quicker to administer, relatively cheaper, as well as scalable in many parts of the world. Hence, antigen testing promises to be one of the key breakthroughs. And we have also noted that WHO has also released guidance regarding antigen testing. So today's session, as usual, will be 1 hour long, which will be made up of 2 quick presentations, and then we go into question and answer. Remember to put your questions and comments into the chat box as the session continues. And we shall take these questions immediately after the question and answer, immediately after the presentations. We will start with Dr. Lara Vojnov, who is a diagnostic advisor from the World Health Organization, and she's based in Geneva. And then we shall be followed up by Dr. Yenu Kebede, who is the head of laboratory services at the Africa Centers for Disease Control and Prevention, Africa CDC, based in Addis Ababa, who will also give us the perspective from the African continent and how we are planning to go ahead with COVID-19 testing, and particularly regarding antigen testing. Ladies and gentlemen, help me welcome Lara Vojnov.
Great, thank you, Anafi. And looking forward to speaking with you all today. I just want to say that the discussion that we'll have today and the guidance that I'll speak to very much has been led by 2 key colleagues in our department here, from Mark Perkins and Jane Cunningham, who unfortunately weren't able to join for the whole call. We're hoping to have Mark join us a little bit to provide some support on the question and answer period, but they've really been instrumental in putting together this guidance that came out on Friday. But first, before we get to that, I thought it would also be important and worthwhile to share with you some additional guidance that also came out on Friday that provided essentially an update of our laboratory guidance for COVID-19. And it touched on a number of the key issues that had been produced, I believe, sort of in the April-May timeline, and just revised them based on some of the new evidence that we have. So I would encourage you to take a look at that piece and think through sort of which aspects might be adaptable for your setting and most useful. As Anafi mentioned, we recently on Friday as well, finally published a key document around antigen detection, antigen-based rapid diagnostic tests. Of course, I think about April or so, we had originally developed a guidance document looking at a number of different RDTs, including antibody-based RDTs, suggesting and really recommending that they primarily be considered in surveillance and perhaps for research use purposes. But as we've been able to gain a fair bit of information and knowledge over the last few weeks, a couple of months, particularly on antigen-based rapid diagnostic tests, we felt it was more possible now to revise that initial guidance and come out with something specific looking at antigen RDTs and how they might be able to support, especially in some of your settings, especially where molecular testing can be a little bit more limiting. So just to start, there are a lot of antigen-based rapid tests that seem to be in the pipeline. I know that for a lot of us who have been working in HIV and TB and others, we've often seen very rich pipelines pipelines that haven't always come to fruition, but this is quite an exciting pipeline that we've seen. This comes from FIND within the ACT Accelerator. Essentially, we see quite a number of technologies that have received regulatory approval potentially or about to launch, with a number of them still in the validation stages and potentially may come on board. Of course, we get a lot of excitement. We've heard a lot of excitement from countries and from others around the potential use of these products to support the pandemic. There are a number of products that have actually been submitted now to the WHO for consideration for emergency use listing. There are 4, in fact, that have done so out of that pipeline thus far. A couple of them have already had their dossier reviewed or are undergoing dossier review. And this is last updated a few days ago and hopefully and generally is updated each week. I would encourage you to go to this website to follow along as products are listed potentially, but as they're also under review. We can't exactly give a clear timeline for when any of these might actually be listed, but the team is working very hard to try to do so relatively quickly, understanding the potential role and importance for a number of countries to supplement their current testing programs with this potential product, as Anafi has mentioned. One of the key pieces around this type of test is really around its performance. And I'll talk a little bit more about why that's the case, but from WHO's standpoint, we've really been trying to gather as much evidence as possible across the board to understand the potential diagnostic accuracy of these products in general, but also of each of the different specific products. As you know, in the emergency use list process, we currently don't have that lab evaluation piece that is normally conducted within the pre-qualification system. So we take a look at a number of different pieces of evidence. Number one is on independent evaluations that are published, that are then reviewed by Cochrane in the United Kingdom to generate one of their typical diagnostic accuracy systematic reviews. And there's been a recent one that's been published a few weeks ago. Of course, by the time sometimes they get published, they're already a few weeks old, but they're regularly going to update these to try and provide us with a little bit more robust data. Of course, FIND is doing evaluations, and I think you've had a number of their team present some of their work here, and on their website you can take a look at those as they're progressing. And we work quite closely with FIND to really stay on top of how some of that evidence looks. And then of course we do have sort of non-independent or supplier evaluations that are done, either included within their dossier or shared in general, that, you know, while not as independent as the others, are able to still provide some indications and really build that evidence base to help us a little bit more in some of the thinking and decisions. So effectively, the primary recommendation that came out of the guidance on Friday is that we do feel that the antigen rapid tests, particularly those that meet the minimum performance requirements that have been laid out by the target product profiles that should very soon be published, of about 80% sensitivity or higher, and 97% specificity or higher, when you compare it to the traditional reference assay, could be used to diagnose COVID infection in a range of settings. And in particular, thinking about, or at least starting to think about, places where molecular testing may not be available, or where we might see particularly long turnaround times that could preclude that clinical utility, first for the patient, but also in reducing potential transmission. One of the things that we have seen, at least a hint to from some of the evidence, is around thinking about how to optimize their performance and really potentially considering the majority of utility of these rapid diagnostic tests that are antigen-based to be within the first sort of 7 days after the onset of symptoms. And this is primarily because of this graph that we see, where the viral load in COVID tends to wane and go down quite a bit early in the after symptom onset. And unfortunately, we then often see as well that the performance of these products can go down with that viral load. And this is just a hypothetical or theoretical graph essentially showing where we expect the potential RDT detection cutoff to be in relation to the PCR cutoff. We still would like to see additional evidence to support this and to really understand the performance at different times, different stages after symptoms, without symptoms, et cetera. But essentially, one of the things that we're considering or looking into and is being hinted is that antigens may not be able to detect virus for perhaps as long as traditional molecular tests might be able to do so. And why the performance is particularly important, and I know this is a topic that we've likely spoken about many times, particularly within the HIV space, when we think about which products to select, where to use them, et cetera, is that if the tests don't have effectively perfect performance, so let's say they're not 98 or 99% sensitive or specific, depending on the prevalence rate within the setting, whether it's within the country or perhaps within a group of patients that you're planning to test, you could see reduced positive predictive values and or negative predictive values. And particularly in this case, if the specificity isn't in the range of greater than 97%, potentially greater than 99%, we could see reduced positive predictive value. Again, I think we really want to have a better sense of those data to be able to really inform it, but this really just trying to think through the potential cases that could happen if these products sort of effectively aren't perfect in the range of 99% sensitive and specific. So if we take a look, if the sensitivity is a little bit lower than what we would hope, essentially that would result in more false negatives, particularly if the prevalence rate was quite low, which would lead to then sending patients who are positive home without necessarily suggesting some of the considerations they should be thinking about. And then there's the potential that we could see increased transmission because those patients think they're negative when they're really not. If we see some reduced specificity with these products, that could lead particularly in low prevalence settings. And that includes, what if we screened everyone at points of entry or in other areas where generally there's relatively low prevalence rates, that could result in an increase of false positives. And one of the key pieces here is thinking about it epidemiologically and whether we might be suggesting potentially some false outbreaks or some outbreaks that may actually not be real, but may be due to some of the test performance. So we're really trying to better understand each of these different tests, these tests in general as well, and think through the ideal usage and utility of them when we're putting the performance into context. And again, we still need to see some of the data to inform us a little bit better there. So there have been a few within the guidance, at least, some cautionary tales to suggest, at least currently, until the performance does improve from these products, that there may be some settings where we want to sort of second guess or think through whether it's the ideal setting for those. And we've listed about 6 of them here. Number 1 would be in individuals without symptoms, unless they've been a person of contact, and that's just because of the low prevalence rates as we spoke about. Where potentially there may be 0 or very sporadic cases, and again, that's the potential concern is if the specificity is not very high, is not incredibly high, then we could be seeing some false positive results and would want to really think through that to not be suggestive of outbreaks that may or may not exist. And this is the case sort of with any testing ideally, but we'd really want to make sure that there's the appropriate biosafety and infection prevention control measures that are in place to consider doing this type of testing, especially since it is decentralizable. And ideally, not just the sampling, but also doing the actual test could be done in quite a decentralized setting. Thinking about how we might manage that patient. If it wouldn't change necessarily, I think there's some questions about the utility of that. But ideally, every patient who gets a test, either on the surveillance side and epidemiologically or clinically, it is a valuable test to be doing. Like I said, there are some questions around the points of entry piece, particularly because of the prevalence rates potentially being variable. But again, I think as we're trying to better understand the performance of these products, that may provide us a little bit more information with which to take this forward. Now, when we want to think about where could these tests particularly, especially right now, start thinking about being useful for countries, and in particular, those countries that really want to maximize and optimize and improve their testing networks. Number 1 would be around the outbreak response and really responding to potential outbreaks that are happening in remote settings and institutions and in communities and whatnot as that's happening, to be able to try and respond much more quickly than maybe we are right now with molecular testing that needs to go to a referral site. It can take a little while to actually do the testing, to send back the result, et cetera. within investigation and contact tracing, and that's a little bit linked to the first one as well, to really be able to do so in a relatively quick fashion in order to try and stop ongoing transmissions from there. Monitoring trends in the disease incidence can be an important piece, especially around among essential workers and health workers during some of these outbreaks. There's a consideration as well for community transmission screening. And this is particularly when we see widespread community transmission. And then lastly, testing of some of the contacts where it could be considered, even if it's not sort of specifically authorized for that use, and just thinking through where we can really maximize this use and how to complement it with the current molecular systems. So within the guidance, we provided some, effectively an algorithm thinking about how we would utilize this test within the programs. Having someone who meets the case definition, doing a swab, running the antigen rapid test, and then thinking through what those possible responses might be in terms of where the prevalence is within that setting and how we might be able to respond. So I'd recommend and encourage you to take a look at that. And then finally, one important or a set of important key considerations, and we speak about this quite a bit, and I know that you've had a number of different webinars on different aspects of this within the COVID pandemic, but also, before, we've had a number of them thinking about it within the HIV, the TB, the malaria space, especially around, rapid diagnostic tests. We always want to be sure that we're training as well as possible and making sure that we're supporting our end users from that centralized setting to ensure that they have all of the tools that they need to be able to run that successful program. And that's a little bit linked as well with post-market surveillance. Fortunately, like I said, there are a number of products that are under the pre-qualification system right now for consideration for emergency use listing. And luckily, there's a relatively robust post-market surveillance program to help us support countries if issues do arise. But of course, each country also should be considering their own post-market surveillance program in order to maximize the quality and the use in their countries. For this infection in particular, we find that the sample collection is really key. And ensuring that it's done well. And so linked to that training is really making sure that the end users are able to do this effectively and then link it to their testing. Quality control, I won't speak too much on this because I know this is a topic that's spoken about a lot in this group, is key to think about how we want to ensure quality control in such a decentralized system. And then as spoken about a little bit previously, biosafety measures for the healthcare workers conducting these tests is really critical. And of course, protecting patients attending those clinics as well to make sure that ongoing infection does not continue. So I believe that's the end. And I just want to thank everyone for listening and happy to take questions later. And Nafi, back to you.
Lara, thank you very much for the presentation. Please hold on to the questions and we will take the next presentation from Dr. Yenu Kebede of the Africa CDC. Yenu, over to you.
Okay, can you see my slide?
Yes, thanks.
Okay. So thank you, Anafi. Thank you, Lara, for that very informative presentation on the recent interim guidance of WHO. And thank you, everyone, for attending this session. Greetings from Africa CDC. After listening into this guidance, and then I want just to present a few slides why antigen testing for COVID-19 response is important in Africa. Looking into the existing data, what we have, and then the progress of the pandemic in the continent. My personal feeling is that the WHO interim guidance looks a little bit conservative. I know why it is, but we can discuss, the details of all technical issues. So let me say this: in the absence of vaccine and specific treatment, immediate identification and isolation of cases, tracing and quarantine of contacts is the main public health intervention to contain or slow progression of this pandemic. This is what I frequently say in all of the presentations. For really, for us to consider testing as the most important intervention strategy for this pandemic, especially widespread testing at early phase of the pandemic. Tests usually after the pandemic has established itself within the community at a later stage may not help unless you want to identify severe case. So I think early testing is very, very, very key. So let me show you this unusual chart, which I got from literature search. This is a scenario describing 4 countries, how they approached their testing during this pandemic: South Korea, Italy, United Kingdom, and United States. So South Korea, even if they were detecting few cases, I think they have been continuously increasing the testing. And both of these 4 countries, they reported cases early January, but their approach was quite different in terms of testing. So you can see how the progress of the pandemic is different among those countries. So South Korea, which has been ramping up the testing at early phase of the pandemic, was able to control the pandemic early as compared to the other member states. Of course, testing alone may not be the only reason. There could be additional factors, but this is also one important factor. So after looking this, can Africa still benefit from massive expansion of testing? It is now more than 8 months since the first case was reported in Africa. However, only 2 countries have registered cases more than 100,000. And 38 countries have reported cases less than 10,000. 25 countries reported less than 5,000, which means that most of the countries are still, at early stage, so they can benefit from a massive expansion of testing to control the pandemic. So still, increasing the testing numbers in the continent will be key. We have still the window of hope for many countries to curb this pandemic. So where is the continent today in terms of testing? A total of 13.8 million tests have been conducted with 10% overall positivity. And this is around 10,000 tests per million population, which means that 1% of the African population has been tested. And if you consider case per test ratio, which experts consider optimal testing, so for every case, the continent is doing 10 tests, which is at the lower side. We could have tested, 30, 20 or so, which means that Africa is still on the lower side of the testing as compared to the cases that are identified. So how is the test performance as compared to projected test numbers? So we use the different models that are out there, including the WHO Afro model of infections in Africa. So the projected testing number on average, looking into the different models, is 63 million. So the continent has conducted only 13.8 million, which is 21.9% of the projected testing number. So there is significant regional differences where the southern region has done 54.3% the projected tests. The north 35.6, east 17.6, and the central is usually on the lower side, as you see it in this graph. So this is annual target, by the way. So which means that we have a long way to go as a continent in cascading this COVID testing to really, to have a better chance of controlling this pandemic before it causes additional health, economic, and social harm to member states. So if I see the weekly testing increase, there looks, especially in the last 4 weeks, there looks a slight decrease on average of weekly testing number. And this coincided with a recent decrease in cases reported in Africa. So I'm really, cautious of interpreting this because what we see on the bending of the epidemic curve in the continent, could it be because we are declining on the testing number? So I think that has to be carefully interpreted. So this is, for example, the situation of the epidemic. So it looks that we are really bending the curve significantly, but as I showed you, there is also a decline in terms of testing number. Therefore, I think I will be very, very cautious to interpret this bending of the curve in the continent. So I assume that it will be too early to celebrate that we are controlling this pandemic. So I am sure, with the introduction of antigen tests, if we increase the testing number, this curve will totally change. So the antigen test, it has been well described by Lara. As you know, this is a simple immunoassay that detects viral protein, so which tells you current viral infection. And the good thing is that it's relatively inexpensive. It can be used as point of care test, similar to HIV testing. And the results are very quick. As you know, on PCR testing today, there is long turnaround time that many people are complaining. As it has been also described by Lara, it performs best at the early stage of the infection where viral multiplication is high. And the downside is that generally the PCR testing is less sensitive. The antigen test is less sensitive as compared to the PCR test. Introduction of the antigen test, it can be used in a variety of testing strategies, as it was described, for diagnosis, screening, or surveillance. When I say diagnostic testing, as you know, this is just to identify current infection on individuals that have signs and symptoms. And it can be also applied on asymptomatic people who have known or suspected exposure. And testing for screening is to do testing of asymptomatic people. And this especially can be used in high-risk congregate settings where community transmission is expected to be high. And I think we can really discuss on the WHO guidance how, in relation to the African context, how we can apply this. And one important thing that at the end of my presentation I would like to highlight is that there are some modeling studies, including this, which I described here by Johns Hopkins, which are really looking into the frequency of the testing as compared to sensitivity of uranolyte. The modeling studies suggest that testing frequency and reducing turnaround time have a relatively significant impact as compared to sensitivity of the test to reduce transmission of SARS-CoV-2. This is true especially in the African context where majority of the population has not been tested, and the turnaround time for our PCR testing is relatively long. Therefore, introducing the antigen test as a screening tool, and also, case identification tool, depending on the prevalence of the disease as described in WHO interim guidance, will be key. Therefore, I would like to inform you that Africa CDC has already engaged partners, including UNITAID, FIND, CHAI, ASLM, and others, to really think about how we can systematically introduce antigen testing into the continent. And some group are already working on training materials. And we are also trying to procure antigen tests, mobilizing also donors for donation of antigen tests. So all of you, the audience here, most likely you will hear from the team how to introduce antigen testing in the continent. So at the end, I would like to take this opportunity to thank ASLM for really organizing this important session, and also partnering with the Africa CDC in all of these lab support activities, and the WHO, AFRO for also working with Africa CDC on this, including WHO Geneva. So as a team, we need to move this thing forward, because introducing the test today is quite different. Will have a significant impact as compared to introducing it 3 months later. So this is a time that we need to act quickly. Thank you very much.
Thank you very much, Yenu, for the wonderful presentation, and thank you again to Lara. Now it's time for the questions and answers. We will take questions from the chat, so keep them coming. And also many thanks to those that are also adding information into the chat box. I see Harry Linda also adding some, so thank you very much. The first question comes from Timothy Sheren, and Timothy is asking about the timing for the testing. He says the individual who is without symptoms but was in contact with a confirmed case, I think he wanted to say, when can the RDT be done? At what day number? I know, Lara, you presented a graph. Maybe we could start there.
This is a good question. And I'm not sure that we really have that evidence at this point to say that it needs to be within this amount of days, or it needs to be, within a certain period after that case may have happened, that contact may have happened. I think this is a piece, and I will say, having looked at some of the chat questions, unfortunately, I think for a number of them, we may not have the complete evidence. And as Yenu rightly pointed out, the guidance at this point is a little bit conservative. And that's because I think, while we do see the potential utility of these tests, we do see how they could really support decentralization, more rapid identification of cases, potentially reducing transmission. There's still a lot that we don't yet know. I think this is one of the key pieces where, we're hopeful that implementation can begin across a number of countries, across a number of different settings, to try and answer and really get to the heart of some of these pieces around the scientific data, but also to really inform on the implementation side. I think we still are very early, very, very early in consideration of these products and how to use them, these types of critical issues, I think. And I know there's some questions around points of entry and which tests are right and wrong. I think we're really sort of looking to yourselves and others to try and help us to generate some of those data so that we can more clearly and sort of freely provide a little bit more definitive guidance.
Yeah, indeed. I think we still have quite a lot to learn, and important questions keep coming through. I'll tie that to recommendations, whether antigen test results could be used to allow or to refuse travelers to cross international borders. I think it is also linking with how do we have an idea on viral load corresponding to a positive antigen test. I think these are important questions indeed. Any comments there as well? Yeah,
I think on the viral load, it's an interesting one that is definitely being looked at. and trying to understand, and of course CT cycle threshold values can be different by different molecular products, but we are trying to understand potential correlation there to try and notify the most appropriate use and whether it can be used with low viral loads. I think on the points of entry piece, it's a really interesting point. It's a good point. There is that sort of those questions around the performance, around the potential prevalence rates, and we do have a team that's working on generating a points of entry guidance document that might be able to provide a little bit more insights into whether that consideration is recommended and potentially, you know, what might be the best tests for that setting. So while we may not have the full answer at this point, the team is working quite hard to try and generate that and share that in a published format shortly.
Thanks again. Yenu, you presented interesting numbers. I think numbers are going up with regards to testing. Earlier, some months ago, we had a session where we talked about the issues of biosafety. And back then, I think point of care testing was really being discussed. And we had, I think, instruments like the Gene Expert into question. I see quite a number of questions related to biosafety of the antigen test. Like Noviana says, what is the level of biosafety for the laboratory that will be using antigen test? I think there are quite a number of questions again, what type of samples that are coming through. Based on the experiences from the field, what could be your comments as we try to roll into antigen testing and safety?
Okay. I think in terms of biosafety, I think Lara, you can comment. But I feel that this is the format of the test is a very simple immunoassay. So I think this can be done with this, you know, biosafety precautionary measures as we have been doing for HIV. So I don't see anything that's creating any aerosol or anything. The most important thing is to be to take, you know, all precautionary measures in preparing the sample. Otherwise, there is no special biosafety requirement to do this immunoassays. These are very simple, rapid immunoassays.
Thank you again, Yenu. As Lara is coming in, there's Mulukeni Kaba and Adino Luli. I think they are all speaking with regards to the quality of testing. Mulukeni says, does WHO has a plan to provide PT panels for this? And then Adino goes on to say, how do we monitor the performance of those kits during implementation, other than the post-market surveillance? I think they are worried about the quality of the kits.
Yeah, so I suppose I can try and jump in, but I might pass some of it to Yenu as well, and perhaps yourself and Afi around thinking through how we might be able to work together to think about that post-market surveillance. That would be really valuable. And I know there are other colleagues on the line as well who have done a lot of work on this, who could potentially support. Just first, you know, agreed with Yenu's comments around the biosafety. I think from our standpoint, the biosafety concerns are just primarily with the healthcare worker who's taking the sample. And that would be the same whether the sample would be used for an antigen-based RDT or for a molecular. In terms of the proficiency testing panel, we have been working quite a bit and with our regions around trying to support countries in this regard. And I think we'll definitely need to look into how we might be able to do so as well for antigen-based rapid tests. But I'm assuming this could be even more of a challenge in thinking about how much more decentralized it will be compared to molecular testing. And so how we really create those quality networks. I think I would turn to Yenu and Anafi yourselves around, you know, what your thoughts would be there.
Yes, thank you. Yenu, you can go ahead first and I'll come in.
I think it's always a challenge to establish quality assurance program for a technology that's coming as new, especially having very characterized panels for enrollment of laboratories into external quality assessment program. In fact, we have made this as an agenda item for the group next week to discuss and to come up with options how we can ensure quality of testing. So as you know, quality also starts from appropriate training of the healthcare workers who are handling the testing, and also checking the quality of the test kit itself. So it starts from the selection of the kit. There are some criteria that are also published with this WHO interim guidance. What type of test kit are we selecting? And then in the lab, I think we need to come up with some recommendations. So I didn't have anything in terms of source of PT panels that we have identified now, but this is ongoing discussion with the different actors, including the companies. So hopefully, as a team, we will come up with something for external quality assessment program.
Thank you, Yenu. Yeah, indeed. I think just like many of the other rapid tests that have come through, I think the common approaches that we have reached out for rapid testing will also be very applicable here. Not repeating what my two other colleagues have mentioned, I think importantly, the training will be very important. Remember, we want this to go as far down the tiers of our health systems as possible. And proficiency testing will be key. So as Yenu mentioned, I think there are plans to have all these being put in place as quickly as possible to make sure that the rapid antigen tests can be as effective as possible as we try to fight the pandemic. Moving on, there is a question which was talking around the media. I will try to take this back to Yenu. I know there was some time Africa CDC hosted a media I think, session. And here it's coming from Joseph. He says, what are the plans for engaging the media in all this? I think this will be key in making sure that people eventually utilize these diagnostics.
Yeah, thank you. I think that's a good question. We have weekly media press release happening at African Union, where the director of Africa CDC responds to any questions that are coming from the media. I see, a very good attendance from the different media outlets on that. And then I think it's important to convey appropriate messaging, especially on the interpretation of antigen testing. So I think we will have some arrangements in describing, to the media outlets when we implement this at country level. And of course, once the member states roll out this testing, then I think we expect also some media engagement at member states level. But from our side, I think we will let the media know in terms of our plan and also the different guidances that we are putting out. So there is already a session going on.
Thanks, Yenu, for responding to that. I'll take the next question from, it's one of those important questions. After all these innovations, all the promise, it boils down to cost. And Peter Owiti says, Nigeria has a population of 195.9 million. At $5 per test, can they afford? Interesting question.
So, Anafi, I'm not really, an economic analyst, but from my simple mathematics, but by locking down the economy as is happening today, how much is member states losing? So if you ramp up testing, investment on the testing, it may be the saving on the other side of the economic scale. But because, if we don't do massive testing and try to control this epidemic as soon as possible, so the longer you lock down your economy, then it will have both, economic, social, and health consequences. I think it requires, comprehensive analysis in terms of economic gain rather than considering this as, the lab testing cost. I think this is true also before, because, when the lab community asks ministers of health or finance ministers to invest in the lab systems to contain any emerging and re-emerging infectious disease, so they don't consider this as a priority, and lab testing is considered to be costly. And but by not doing that, you have seen, how a single organism can really, stagnate the economy of the whole world. So I think it's not like 1 + 1 = 2. So economic scale analysis should be very complex, as it has to involve, many aspects. Over to you.
Thank you, Ian. That's quite important indeed. And I pick similar comments from the chat, like Mohan says cost, it has disappeared, but I think he agrees with what you were saying. Cost is the price one pays for not utilizing it in an outbreak environment, and then saving lives versus saving livelihood. It cannot be a trade-off like what economics thinks. So it is necessary to balance both. Important reflections indeed. There are quite a number of technical questions that were coming through in relation to cycle threshold. I'm trying to pick one from. He wanted to know what are the trade-offs with regards to thresholds, and this is the name is not coming out very clearly. Luhubung, how about sensitivity and specificity of rapid antigens? Because I found some false negatives, especially for positive PCR with CT values above 30. I'm not so sure whether they have already started some independent evaluations to share. Ara, you touched a bit on some studies, maybe shed a bit of light.
Yeah, I think I'm happy to. And I might actually suggest, I see that our technical lead, Mark Perkins, is on, who's been looking very closely at the performance and as it relates to the cycle threshold values and some of those challenges. And I might suggest that you perhaps, and I see you just did, unmute him, and he can provide some feedback on that question.
Mark, please, thank you, welcome. Please go ahead, unmute and comment.
Thank you. So obviously what the CT value means in terms of the amount of virus in the specimen varies per assay. So you can't say a CT value of 26 always equals 1 million copies per milliliter. You can just say that in this assay, in this particular assay, that's what the analytics show. But that being said, the assays are rarely more than 2 or 3 points off from each other, two or three CT values off from each other for the same input virus. So the studies have shown that if you look at people with CT values below 30, that is a moderately high viral load, that the tests perform well, and the sensitivity of 80 to 90%. At least the well-performing tests perform well. and that if you move that down to a CT value of 25 or so, you essentially can detect with the good assays almost all of those patients. So that is the good news. The bad news is that you will be missing patients who've come in either very early in disease where they don't have, and they're asymptomatic and they haven't yet got much virus, or they've come in with 10 days of illness and are outside the time frame when they would have lots of virus. So these tests are recommended, and many of them are regulated for testing only in the first 5 to 7 days of illness, because that's when the viral loads are highest. But there's no concrete cutoff for CT values in detection, but in general, the performance is high at 25 to 30 CT values maximum.
Thank you for that insight, Mark. Very valuable indeed. I think, again, around the technical issues, we also have Vasundara coming in with also the element of algorithms. And he says sometimes antigen test is being put in place of real-time PCR, but because of an improper algorithm combined with low sensitivity, the negative test results are taken as negative. So I think as antigen rapid tests are coming through, we need to think of algorithms. Any comments?
Yes, we definitely need to think about algorithms. The guidance document offers an algorithm, or a couple of algorithms that are common in settings where you have access to PCR only remotely, where you'd have to ship the PCR somewhere, and where you could make use of near patient testing results from an RDT in the meantime, and settings where you don't have any PCR access. And unfortunately, it's all about trying to understand the pre-test probability. We've been spoiled by the high performance of PCR assays for several decades now. And we realize that the decision-making now with simple tests, RDTs, for example, is still important. So we still need to be able to assess how likely do we think it is before we test this patient that they really have the disease. And that pretest probability drives everything that happens afterwards. So it's easy to set up an algorithm and say which patients you should definitely exclude from testing with an RDT. So those would be patients in which you wouldn't do anything with the result, or there is a very low probability that they have the disease. So for example, non-asymptomatic people who are not a contact of a case are very unlikely to have the disease, so they shouldn't be tested. And that would include, right now, settings of points of entry or at border crossings, where most of the people coming across are travelers, workers, truck drivers, etc., and are asymptomatic and not a close contact with a case. And in that setting, the specificity is such that the predictive positive values are not high, and you'll be more likely to miscall a bunch of positives as positive when in fact they were negative. But this is the complexity of trying to make these decisions in real time, because you don't have a color chart simply can tell you the right answer. That being said, we are looking into the possibility that if you change the cutoff from a faint band to a 1+ positive or 2+ positive band, that you could increase the specificity, but we don't know this yet. So it's just a theory, just an assumption.
Yeah, indeed. We continue to learn, indeed. One of the other important aspects that comes with the new diagnostics, which we have struggled in many places, is by the time countries adopt the diagnostics, I think we have lost quite a potential to save many people's lives. And it has to do with issues of validation and verifications. Question from Maria Lopez. She's asking, do we have protocols for verification of antigen test kits? If so, can we please share? And then this one from Augustine. Augustine says, I think country-based validation data is critical prior to deploying for population use. And we are always having these issues of what is the trade-off if others have already done it.
Yeah, those are both very good points. It is really important, not just that you, whether or not you purchase a antigen detection assay, but which one specifically it is. These are each biological devices with multiple different reagents in them, different antibodies, different buffers, different dyes. And if you don't, if you assume they're all the same, you are making a mistake. Some of them perform much better than others. There are some companies that inoculate animals and pull out a few clones and look at whether or not they bind to the antigens, and they're ready to go. And other ones pull out thousands of clones to assess which antibodies they're going to use. So they're clearly important distinctions between the tests. But once you've decided to purchase a test, then how are you going to validate that it performs in your hands the same as it performed in the company's hands, or that it performs in South Africa or Guinea the same as it performed in the laboratory it was developed in wherever that was? And that is, we have not published protocols, and I think it's a really good idea to validation protocols on how you would tell whether or not a new test that you've just purchased is working. And unfortunately, this is not easy because you either have to have a specimen bank of reference clinical materials, sputum, oropharyngeal swabs, nasopharyngeal swabs, in buffer or not in buffer, that are frozen, etc., or access to populations where you have access to PCR and can tell whether or not, in fact, the patients really are infected, and then validate the test results. Some of these tests will come with control materials. That is, they will come with an engineered or purified proteins from the virus, and you could use this to verify that the tests are working. And you could potentially do dilutions of these to ensure that the people can still detect them even though they're diluted. But we haven't got protocols published for this, and I think it's a good idea that we do so.
Thank you, Mark. And I think George has entered an important comment in the chat. Maybe George, if you are there, maybe try to emphasize, I think, the recommendation around repeated evaluation.
Did you want
Hello,
to, George?
Are you getting me?
Yes, yes.
Yeah, good morning and thanks. This is George Alamjis from OGAG in Washington, PEPFAR. Yeah, just want to say that we've seen a lot of delays in deploying some of this very good technology because of the politics and the bottlenecks of in-country repeated evaluations. So if WHO has undergone through all the rigorous evaluation processes and it works, I think countries need to minimize the process of deployment to simple verification and ensure that this is deployed as soon as possible. We're talking about patients and urgent need, as you've heard from, the need for us to quickly identify and be able to quarantine or separate individuals. So the more countries delay the process because of the in-country politics, the more the infection is spreading. So countries need to minimize the process and make it simple. Over.
Thank you, George. Yeah, this issue is always a very important subject altogether. From the ASLM perspective, we have some protocols that we have made, and I think my colleague Margarita online will be sharing these as well around serology tests. We have a question from Southeast Asia, and this is also applicable to many of us here across the African continent. And this is from Kin Oho, who says, our country in Southeast Asia is experiencing acute rise in cases and rising mortality. There's always a high backlog of PCR testing, especially for contacts and those in quarantine cases. But the lab lacks confidence in antigen-RDTs, as there were many false negatives compared to PCR. will it be justified to use RDT to screen those backlog samples, although the false negatives will be a source of more transmissions within the community? I think it's a practical situation on the ground. As these are coming, can they be used to deal with the backlog?
So it depends on how you have the samples managed. If the samples have been inactivated for PCR testing, then you won't be able to generally use them because the proteins that you discover for antigen detection will have all been refolded or misaligned. So degraded in some way. So you could use prospectively the assays to decrease the amount of testing. So if you were specifically, for example, looking at busy emergency rooms and wanting to test and qualify those individuals as high risk early, then you could presumably screen those patients with their antigen detection tests and then confirm only the positives and put them all in isolation while you wait. And that would allow you to prioritize your PCR for the most susceptible or likely people. But in terms of having a bank of specimens that you would then test, you could do the same thing depending on how the specimens have been stored. Now, from a commercial point of view, the company may not have done the test to prove to the manufacturer, to the regulatory agency, that they could store the samples for 2 weeks and then test them, they would still work. So it depends on how they stored them, when they stored them, and whether or not it meets the demands of the instructions for use of the assay. Whether you could use that to validate the assay, or whether you could follow those, declare those patients as having been diagnosed with an approved test. So it's better to do it prospectively.
Yeah. Thank you, Mark. There are quite a lot of these questions in the chat. So we will request that maybe these could be answered, I think, even by writing, so that we can share and take them along this session as we post the slides on our website. And, there were also questions about slides. We, as usual, are going to be sharing with you these that have registered through for this session, as well as you will always find them on our ASLM resources page in a couple of days. I saw quite a couple of questions around downloading the certificates. I think my colleague David has provided some instructions in there, but should you have challenges, please feel free to keep on checking with us. Time is always a challenge when we are talking about these important issues, but I'm glad we managed to learn quite a number of issues that are coming through. I also want to notify you that at the end of this month, issues around performance of the test were coming in strongly as usual, and we will dedicate a session where our colleagues from FIND are also going to be sharing evaluation results for quite a number of test kits that have done. So look out for that session soon. But before that, we are not forgetting concentrating on HIV and TB in order to maintain the gains that we have made thus far. So we will be focusing our next session on strategic communications on how to make sure that the demand in the testing for HIV and TB continues. And our colleagues from ITPC will give us some insights on how they have been doing it. Yenu, in just 30 seconds, a quick remarks.
Yeah, thank you, Anafi. I think in line with what I was mentioning before, it's good that now WHO came up with this interim guidance. I think we as Africa CDC have been trying to push both antigen and antibody testing long time ago, looking into the real challenge that African countries are facing in cascading the testing using PCR technology because most of the countries do have 1 or 2 labs to do PCR testing, and it was practically impossible to meet the testing demand that's needed for COVID response using centralized testing. So this is a real opportunity. So we will regroup as a team and come up with, a strategy how cautiously maintaining quality of testing, we can introduce this antigen testing in member states. Initially, we are planning maybe to consider on 20 countries or so. And then based on that, we will enroll other countries as well. I think we as Africa CDC value the support of all of the partners and the hardworking people in different laboratories that are really struggling with the high testing demand of this pandemic. So I would like to thank all the participants here for this very informative session, and would like to thank again ASLM for organizing this wonderful session. Thank you very much.
Thank you, Yenu. Lara, just 30 seconds.
Sure, I'll be very quick. But I just want to thank Yenu from Africa CDC, my co-presenter, ASLM and Anafi for giving us the space to present this new guidance. And thank everyone for all the great questions. Unfortunately, we may not be able to answer all of them quite yet, but hopefully we'll be able to reflect on those as they're, as they're developed, as they're published, and be able to update our guidance accordingly. Like, as Yenu says, I think we really see this as a great opportunity, and I think there are a number of steps that still need to happen to move forward, but we're really looking forward to better understanding, to working with your countries, better understanding where the use might be considered in your settings, and sort of having you speak to us in terms of being able to move forward. So just want to thank everyone and wish you a good weekend.
Thank you, Lara. And I also want to thank Mark for coming through and attending to most of our technical questions. And thank you everyone for joining. As usual, we appreciate you sharing information. Until we meet again,